talking about ablation, I have personally some experience with some non-thermal ablation, but I have to say that the 3 thermal ablation modalities that really work for the lung is first of all the microwave ablation, the cryo, and the radiofrequency ablation. You can use all the 3 modalities. They have drawbacks and some advantages that I like to summarize here is microwave is faster. You have generators that can apply up to 150 watts, but my first recommendation for lung ablation is do not use, please, all the power of your device. I would recommend to stay close to 80 watts or less than 80 watts. Prefer to take time with microwave ablation. Ablation will be faster than with RF or cryo. Take more time, 2 or 3 minutes more, but don't go over 80 watts. For cryo, advantages is supposed to be not to be painful. So the majority of colleagues who are using cryo also using cryo for lesion close to the thoracic wall. This is a potential advantage of cryo. If you use microwave and RF with general anesthesia, you will not have the problem of pain, but if you use, like in my institute, we use mostly only local anesthesia, not the general anesthesia, cryo could have an advantage here. Also the no-touch ablation, which is in my experience more important if you treat primary lung cancer than if you treat metastasis, because the leishmaniasis carcinomatosa around the tumor is larger than primary lung cancer, but the no-touch ablation could be an advantage for cryo. It's a little bit more expensive, and if you remember the slides before, you need more applicators or cryo applicators than for microwave ablation. The problem of radiofrequency ablation is well known, the INSYNC effect, you know this disadvantage or drawback of RF for ablation in the liver, that's the same for the lung. You have in the lung also vessels. You have also bronchi that can produce this INSYNC effect by using radiofrequency ablation. This paper we published many years ago. We were looking at the effect. We were performing lung ablation at the beginning with radiofrequency ablation in where we looked at the effect of large vessel. And as you can see here, a tumor with a large vessel. Large vessel is more or less defined as a vessel larger than 3 millimeters. And it was an ablation resection study. So we performed ablation, and one day we performed resection. 3 days after the ablation, the histopathologist look at the shape and the deformation of the shape of the coagulation, and you see that there is a strong deformation on the shape of coagulation here if you are close to a large vessel. And Dr. Higuchi demonstrated the same problem when you have bronchi. Large bronchi will also lead to this deformation of the shape of coagulation. It seems not to be the case for microwave. You know, microwave is not only faster, it's more energy and higher temperature when you use microwave even in the lung. And this animal experience coming from Paris shows that there is no INSYNC effect with microwave for vessel up to 6 millimeters. Look at this, what happened over the last year. I had the honor to publish this standard of practice, and you see the conclusion was very, let me say, very vague. What can we do? Ablation of thermal lesion is feasible, it's cheaper, but we have much more experience in the last year. And look at this, moving from 2012 to 2020, now we have clearer indication for primary lung cancer, T1A and T1B, and we know that we are differently successful by treating lung metastasis for renal, for thyroid, for colorectal, from colorectal cancers, and for treating metastasis for sarcoma, for example. So it's more than a work in progress. We have several evidence now. And this is the reason with all the evidences we produce in the literature that lung ablation is now recommending in Europe by the ESMO, European Society of Medical Oncology, especially for patients with respiratory insufficiency or with some comorbidity, of course, but you can perform ablation of lung metastasis in colorectal cancer for patients with less than 5 metastases. It's the same, similar with less details, but similar. There is some recommendation for ablation of lung metastasis in different primary disease, as you can see, colorectal cancer, lung metastasis from sarcoma, and lung metastasis for renal cancer. How do you do lung ablation? There is, in my opinion, 3 different possibilities. What I do in my institute is with local anesthesia. I like to have the contact with the patient and to say, okay, please take a deep inspiration or not so deep inspiration to localize the tumor. It's very helpful. And in the large majority of cases, lung ablation is not painful for patients. We perform by ourselves sedation with remifentanil. So with 2 other possibilities, of course, to perform with general anesthesia, either with a single lung ventilation or with a jet ventilation. There is some advantage, but be aware of one point, is if you perform lung ablation with a single lung ventilation, the extent of coagulation will be larger, more or less 30% larger than without single lung ventilation. So be aware about that. The extent of coagulation will be more by performing lung ablation with general anesthesia. This is an example, and personally for lung metastasis, I would make a differentiation between lung metastasis smaller or up to 1 centimeter and the one larger than 1 centimeter. If we talk first about up to 1 centimeter, you have always vessel and you have always bronchi in the periphery of the tumor, but you can place your needle or your applicator just close to the metastasis. That's possible. You have to pay attention, and I will come back on that. It is the monitoring of your ablation that you can perform with, by looking at the ground glass opacity during your ablation in a pulmonary window. So what you do is to place close to the small tumor, because it can be very difficult to stick a tumor with 1 centimeter in size. What you can do also is to use another device, to use here an umbrella needle, so you can come very, very close to the tumor and extend your electrode over the small metastasis. That has also the advantage that you stick the small metastasis inside your electrode, and you have all the time to perform your ablation. You can also retract the needle in the case you have a small pneumothorax. But pay attention to that point. If you have 1 electrode in a bronchi on a vessel, there is some devices that are not able to work and to deliver energy if 1 electrode is in a vessel, in a bronchi. And the most important is, with the lung, you have always the possibility to control the extent of coagulation by looking at the ground glass opacity after your ablation. If the tumor is larger, if the metastasis is larger than 1 centimeter, it's much better to stick your tumor, as you can see here or in this example, and pay attention that the ground glass opacity is all around the lesion you have treated. And for treated lesion close to sensitive organs, like in this case, very close to the aorta, I would not recommend, as you can imagine, to use an umbrella needle, but better to use a straight needle, so you have a better control of the position of the electrode. Also pay attention if you are close to the interlobium, like in this example. We always perform NPR reconstruction, and also prefer here to use a straight needle, RF or cryo or microwave, to avoid to have 1 electrode moving on the other side. If you have a small lesion close to to sensitive organ. Here the mediastinum, the heart. You can use the umbrella needle here, and you should extend, as I said before, all the electrode around the tumor. You see an example here. It is an ideal case to use this umbrella needle because you are close to the wall. The lesion is at the periphery, and the lesion is quite small, 1 centimeter. And you control the exact position of your needle in an ampere, and of course you control the ground glass opacity at the end or during your ablation. It is a case I would recommend to use fluoroscopy for different reasons. First, it is a case with sensitive organ, very close to the tumor, and you have very large vessel. So in that case, I prefer to use fluoroscopy. Fluoroscopy makes your function very, very fast. You see here some online. You see that you use also the respiratory motions from the patient. You can advance your needle, it's a straight needle in that way. And you say to your patient, okay, take a deep inspiration so you can stick the needle when the vessels are not on the pathway of your needle. And it seems to be very, very easy. It is very easy, fluoroscopy, but I would strongly recommend one thing is to always control the position of your electrode with MPR after placing it. In this example, you see it seems very good, perfect, just between the vessel, but you see that the position is not really optimal, it's at the bottom of the tumor. You have two possibilities in that case. You perform ablation in this position, and you remove and you perform a second ablation at the top, just to be sure that you have the GG all around the tumor, or you move from this position to another position, more central position. And with microwave, you are able to treat this small metastasis with one ablation. Just to show you, if you want to start with lung ablation, don't start with metastasis larger than 2 centimeters. You see, it is the largest paper, the largest series that has been published for ablation of lung metastasis coming from several hospitals in France. And you see that the overall survival is different, following some criteria. And the green line with the best result are patients with only 1 met with a size smaller than 2 centimeters. Metastasis from colon, from CRC, and from kidney, and a disease-free interval between the primary diagnostic and the diagnostic of lung metastasis. This is the best case if you want to start ablation. Anyway, in interventional oncology, if you want to start a new modality, you have to be successful at the beginning. So choose this patient instead of this patient, where the success of your ablation will not be the same. To conclude, just a follow-up, because the follow-up is very important. I have 2 messages for that. Perform the follow-up by yourself,